Hello, my name is Ashley. I just want to thank everybody for sticking with me. So we'll get home soon. But like he said, I'm doing my project on reducing HIV/AIDS disparities among African Americans. So I did this last semester in Intro to Public Health, and it was an evidence-based project where I just looked at current literature on different programs that are in place for HIV/AIDS prevention that target African Americans. So just as a quick introduction, African Americans are disproportionately affected by HIV/AIDS, and current research has shown that the past behavioral intervention programs have not been effective in changing their behavior or reducing risky sexual behavior. So again, the purpose of the presentation was to just examine current behavioral interventions that target this population, as well as how to engage in healthier sexual behaviors to empower them to sustain them over a longer period of time. So just starting out, this is our national goals, or the national strategies that we have in place for HIV/AIDS. And what my presentation is highlighting is the related health disparities, and that's there in bold. But those were the 4 goals that we're aligning with. But I wanted to focus on the health disparities. So I broke the presentation down into 3 core functions of public health, which is assessment, policy development, and assurance. So I'll start with the assessment piece. So just for a quick scope of the public health issue, one of the literature reviews that I've read noted or suggested that African Americans aren't at greater risk necessarily because they engage in more riskier behaviors than other races, but it also suggested that because of their geographical and social environment, it elevates their risk, and this is known as geobehavioral vulnerability. So just the fact that they're in areas where the incidence and prevalence rate of HIV/AIDS is extremely high, that increases their risk naturally. The second scope of the public health issue that I wanted to comment on was communication that are given from parents to children. And from the research that I've found, a lot of the communication is focused on avoiding pregnancy, trust, and then just control of sexual impulses, but little communication is given as far as the risk of HIV, and in turn that kind of lowers the perceived susceptibility of young African American females and males because the communication isn't there, so their perceived susceptibility was very low. And then racial disparities are also seen within STD rates as well. So we know that STD infections facilitate into HIV transmissions. So a lot of HIV-positive individuals also have other STDs, and they're likely to spread HIV to others. The next, I wanted to look at the impact of HIV/AIDS on the population. So the incidence and the prevalence rates have mirrored and occasionally surpassed estimates in sub-Saharan Africa and the Caribbean. And I know from just recent research that I had to do for another class, DC is about 10 times the national average of the incidence rates for HIV. And I believe it's about 1 in 10 adults in the DC area is HIV positive. So a lot of the rates here in America is matching up with other countries. African Americans account for approximately 13% of the U.S. population, but they represent over half of new cases of HIV/AIDS. And so this statistic alone was very alarming to the CDC, and it caused a heightened response of us looking at the current programs and how we can change it to make it more effective. And then another impact was the older African American women ages 50 to 64 are the most vulnerable to HIV infection, and we're starting to see an increase of incidence rates among this population. And they comprise nearly 40% of new diagnosed cases. And from the research that I've found, a lot of that is just their attitudes. Because these women are older, they're not necessarily worried about pregnancies, so they don't see condoms as necessary as, say, someone in their early 20s, 30s who's trying to prevent a pregnancy. So that leaves them more vulnerable to HIV because they don't believe that using condoms is necessary in their sexual relationships. So the two main contributing factors that I found were power differentials as well as risky sexual behaviors. Excuse me. So as far as power differentials, women typically conform to the wishes of their partners. So if their partner didn't enforce condom use or bring it up, they didn't, as well as just the confidence in themselves. A lot of the literature spoke of women not feeling confident to bring that up and to make it a point to use a condom in every sexual encounter. And then as far as risky sexual behaviors, a lot of women believe they were in monogamous relationships with heterosexual men, and that, of course, made them more vulnerable when that wasn't the case. Again, women believe that suggesting condom use would jeopardize their relationship with their partner. So a lot of women felt they would rather take the risk of possibly getting, HIV or another type of STD just to keep the relationship or keep from putting stress on the relationship. So moving into policy development, I had initially focused on 5 behavioral intervention programs, but due to time constraints, I'm just going to focus on 3. So the first one was Voices, or Voces, which is the equivalent, but the Hispanic Spanish taught version. It's a culturally relevant video that reaffirms condom use and condom negotiation skills. And the facilitator leads participants in group discussions and role play exercises to practice skills that they just saw in the video. And a good thing about the program is that it's cost effective, which is very important in the field of public health, to have a cost effective program, but it can also be easily integrated into other settings or services. So this particular study, it was integrated in like a after school setting as well as a health department, kind of like a county fair, offered it just for the participants that came out. So since it's mainly just a video and then the facilitator leads it, it can be easily integrated into different settings. The second program that I studied was entitled SISTA, and it was specifically created for African American women by the CDC. And it's a 5-group based session with the option of 2 booster sessions if the facilitator felt it necessary. It's gender specific and culturally relevant, and it can be adapted for any age. And it's led by an African American female facilitator, and research has shown that the facilitator that leads it, if the audience can have some sort of relevancy to her, the message is kind of a little more seamless. So they felt that that was an integral part of this program, is having an African American facilitator teach it to other African Americans. And the skills training component that was included in this program was communication, negotiation skills, and improving partner norms support of condom use. Okay, and the second policy was geared towards African American teenagers, and this was entitled BART, which is an acronym for Being a Responsible Teen. This is an 8-session group-based and is designed to reduce risky sexual behaviors and improve safer skills. And in this program, adolescents learned problem-solving, decision-making, communication, condom negotiation, and the following. And the delivery methods were very varied depending on the setting. So you could do a lecture, a group discussion, role plays, or videos. So it was pretty varied, and however it was deemed most appropriate for that group. So moving on to the insurance piece, each program was evaluated for its effectiveness. So for the Voices program, the participants that was in the program was recruited to complete the evaluation, and they were given a question developed by the CDC, and it was either done via over the phone or an in-person interview. And the results from the evaluation, on average, all sexual risk behaviors decreased from baseline to follow-up, which occurred at the 1-month mark, and then there was a second follow-up that occurred at the 4-month mark. And this graph just depicts the evaluation from baseline all the way through to the follow-up. The evaluation for the sister program, it was also done over the course of the program. Then the participants were recruited when they enrolled in the program. Participants completed an in-person interview within 30 days before the intervention started, which served as the baseline data. And then the follow-up interviews took place at the 90 and 180 day mark following the very last session. So the results from this evaluation, the participants reported a decrease in the number of sexual partners, their sexual events, unprotected sexual events, and unprotected sexual events while intoxicated. The positive outcomes was sustained up to 180 days following the intervention. So that was really promising because it just showed that the behaviors that they learned during the program can be maintained up to 180 days. And the evaluation also discovered that the reduction in factors was consistent across a variety of site types and age of participants, which is also very promising because that means the program can be replicated for different age groups in different settings, and they expect to see the same results. And then for the third program that was evaluated, these participants was separated into two groups. So there was teenagers that was involved in the actual BART study, and then the control group, they were just given just your general sexual education class that you would get like in any normal high school setting. The sexual behaviors within the past 2 months measured directly after the intervention and at the 6 and 12-month follow-ups at the end of the program. And the results show that significantly lower percentage of students that were in the BART group reported being sexually active compared to the youth that just got the general sex ed class at the 12-month follow-up. And also the sexually active BART group reported a significantly greater percentage of sexual intercourse that were condom protected than the youth, the general sexual education. And this was seen at the 6 and 12-month mark. And this is very promising because it shows that these behaviors can be maintained even after the end of the program. So in conclusion, just according to the new approaches for HIV/AIDS, we believe that if the program is both gender and age specific as well as culturally relevant, it seems to be more effective with the audience in reducing their risk of HIV/AIDS and sustaining the healthy sexual behaviors that they learn within the program after the program. And then it's also vital to utilize the 3 core functions of public health: assessment, policy development, and assurance. And something that we studied in class, that a lot of the programs will focus on the assessment and the policy development, but they don't come back to evaluate it to see if it's actually effective. And I believe that's, the key piece is to make sure that the program that you're actually presenting is effective and it's doing what you intended it to do. And then just recommendations for future work. I believe that more research should be done on older African American females. I feel like they're often overlooked because they're also often stereotyped as not being sexually active. So this wouldn't be an issue for them. But as data have shown, the rates of HIV among 50 to 60-year-olds are increasing. So I believe more research as well as intervention programs that target this specific age group should be looked into, as well as exploring what can be done to reduce the stigma around HIV/AIDS, because the stigma has a lot to do with a lot of unreported cases and delay for treatment. And that was my presentation. Thanks.